Good morning, everyone, and I am here to fill in for Dr. Shobhit, who could not be here. And the topic that I am talking of today is earlier vitrectomy better in vision-threatening PDR? We know for PDR, the treatment options in our armamentarium are the entire gamut of anti-VEGF injections, laser photocoagulations, and also vitrectomy, all of which have their specific indications with specific advantages and disadvantages. When we talk of anti-VEGFs in PDR, they have shown promising results in decreasing the progression of PDR to tractional detachment. More importantly, it decreases vascularity and aids in the future treatments, but also is a smaller procedure, very easy to do. But it comes with its own disadvantages, like a limited duration of action, has a crunch effect on very vascular PDRs. We cannot underestimate the cost burden that it puts with the burden of multiple visits and travel, and is also unreliable in a good amount of patients who are lost to follow-up, which cannot be underestimated, especially in diabetics. So if you look at the protocol S data at 5 years, we see that 14% of these patients required PRP, 48% developed VH, 3% developed a neovascular glaucoma. But more importantly, a lot of patients showed progression to tractional detachment, which 19% of which required vitrectomy. We move to the laser photocoagulation in PDR, which has been the standard of care and kills the hypoxic areas and is also cost effective. But it can be limited by the vitreous opacities like cataract or vitreous hemorrhage, which are not uncommon in PDR patients. Anterior retina may remain untreated, which may lead to a neovascular glaucoma. PRP can also increase traction in a certain subset of patients of PDR. Again, when we look at the protocol S data, at 5 years, 45% of patients who had already undergone PRP required an additional sitting of PRP. 46% developed VH, and 14% required vitrectomy. Another study by Khan et al., which showed that at 10 years, 89% of patients required additional PRP, and a good amount of 33% required vitrectomy. So till now, the traditional indications of vitrectomy have been huge, but the most common indications being a non-resolving vitreous hemorrhage and a tractional detachment, which involves or threatens the macula. Early proliferative diabetic retinopathy with or without pre-retinal hemorrhage comes very lower down the list. If you look at this patient, a patient of ours, 43-year-old female, presented to us with 660 vision. On the OCT showed minor traction at the macula. It was getting detached. Some amount of subretinal fluid was also there. He was already lasered with some skip areas. Now, at this point of time, the patient was not ready for a vitrectomy. However, we convinced him. We tried to convince him, but he did not. 3 months later, he came to us with 460 vision, increase in traction, increase in the fibrovascular proliferation, and increase in the detachment at the macula, and ultimately had to undergo a vitrectomy. In comparison, this was a 62-year-old female with a 6/9 vision, very stable. But if we look closer, along with the fibrovascular proliferation, had a small amount of SRF which was peeping. It was still not coming to the macula, hence explaining the good vision. This patient we took up for a vitrectomy at this stage, and even 1 year later, she was absolutely fine with a maintained BCVA of 6/9. So why are we talking of early vitrectomy? We have seen that long-term follow-up of vitrectomized eyes in diabetic retinopathy versus the non-vitrectomized eye show that there are lower rates of additional treatments, lower rates of progression, better best corrected visual acuities with a stabilized anatomical and functional outcomes. So is it that we should consider early vitrectomy in all cases? Well, not really. The thing that we have to look for is the vitreous status. And we all as vitreoretinal surgeons know that vitreous scaffold is our enemy in diabetic retinopathy cases. A large study by Ono et al. Saw 400 patients where they compared or assess the proliferative diabetic retinopathy with the posterior vitreous detachment. And they saw that in patients who had complete PVD, 0% of them progressed to a tractional detachment, whereas 100% of the eyes which had partial PVD progressed to either vitreous hemorrhage or a tractional detachment. About 44% of eyes progressed to a to tractional detachment where there was no PVD. So the role of vitreous cannot be underestimated. In cases where there is a complete PVD, new vessels can only grow on the retinal surface. There is no vitreous traction for bleed or a tractional detachment, and hence, when treated with laser, can have a sustained stability. Essentially, vitrectomy does the same thing. Vitrectomy removes the vitreous scaffold, which is responsible for progression, and hence, early vitrectomy can help in these patients. So the goals of vitrectomy are clear. First, we remove the vitreous opacities and remove the fibrovascular membranes which are causing traction. It is important to remove the posterior hyaloid and all the second or the double membranes, which was very nicely shown by Dr. Dave. We release the tangential and the anteroposterior traction and control all the bleeders to attain a good surgical outcome. So if vitrectomy is so nice, what has stopped us from doing an early vitrectomy till now? So till very recently, the vitrectomy systems did not allow us to have good surgical outcomes. The incidence of the iatrogenic breaks were high, and the anatomical failure ranged from 7 to 22%. There were cases which experienced visual acuity loss post-vitrectomy and ranged till about 34%. But it's also important for us to know that this is the data where the patients were operated on advanced PDR or tractional detachment with poor retinal perfusion and poor systemic control. So what has changed? Now we have smaller gauge of instrumentation, we have better fluid dynamics in our vitrectomy machines, high cutting speeds, and good pressure controls. We have anti-VEGF agents for pre-op control and wide-angle visualization or 3D visualization, which can lead to better surgical outcomes. We look at the cost effectiveness and we find that the total cost of burden of vitrectomy is comparable. When we do an early vitrectomy, there's long-term stabilization with lower rates of repeat procedures, whereas in other treatments, there are additional treatments which will be required over the years. The progression is common, and hence they might need vitrectomy anyways in future. We cannot underestimate the cost of travel, visit, and work loss. So to conclude, our focus should be on better functional outcomes rather than only attaining anatomical outcomes. We see a shift in vitrectomy systems. We have better instrumentations now. We should always consider the vitreous status and the systemic status. In today's world, it is important that we should evolve rather than just adhere to the old paradigms. Thank you.
Thank you, Dr. Komal. I think you've covered most of the things. Another point in disregard for early vitrectomy would be, in my particular case, what happens is these patients are going to have a tendency to develop macular edema. So if you can avoid a vitrectomy in those situations, then in that situation, but anyways, we have to wind up the session.